Hi, everybody. Thank you so much for joining us today. We're joined by Steve Garari, the CEO and Managing Director of Actinogen. We think Actinogen is an incredibly exciting biotech. And also, just to back up for a second, we all know that the markets are a little bit wobbly out there right now. People are very uncertain. But that's also why we do like biotech, is because you can get companies that are much more stock specific, that do control their own destinies. And ultimately, when you're trying to solve those big healthcare issues, clearly, I don't care what the market is doing, there's a place for that always somewhere out there for some type of blockbuster new drug or new invention that has to do with, making people live longer and more healthy lives. So with that introduction, Stephen, welcome to Off the Charts with 180 Markets.
Thanks, Greg. It's a pleasure to be here.
Hey, Stephen, since you've taken over the company, Actinogen, it's probably been, I guess, about a year, maybe more now. You've really, ignited it, and that's because you've certainly had a lot of success yourself previously. Could you just share with people a little bit about your background?
Yeah, sure. Thanks. My original background was training as a specialist medical physician in Melbourne, and I did a PhD in clinical trials and biostatistics and went to the US in the 90s, where I was lucky enough to work as a postdoc at UCSF and then Genentech for many years in the early days when that was valued at less than $1 billion, believe it or not, the original baby biotechs, and then had a lot of success there with a lot of different marketed drugs. And after a spell as a VC, I also went back to the US and went to a company called Principia as the founding chief medical officer, and took a number of different small molecule BTK inhibitors in immunology and immune diseases through from first in humans, which actually we did here in Australia, to successful phase 2 and phase 3 programs. And that company was eventually sold to Sanofi for about $3.7 billion. Not
too bad. And yeah.
And sorry, the reason Actinogen's got a great program, but it also represents a very similar opportunity to me as Principia did. So I joined that company and put some of my own money into it when it was, about 100 million valuation, and believing in a really good team and really good science. And that's really the same situation we have here at Actinogen.
Yeah, and that was going to be my next question, was what attracted you to Actinogen? And maybe since you've answered that, can you just talk a little bit about, and then we'll drill down, obviously you've had some exciting news out today in it as well. What is it that Actinogen is exactly trying to solve for? We know that, it's everything to do with the central nervous system, but maybe just give it a little bit more specificity.
Yeah, so our lead drug called Xanamem is a small molecule or daily pill or capsule that the drug travels into the brain and inhibits the production of the stress hormone called cortisol. And that's been strongly associated with deterioration in mental abilities. In fact, our cortisol in the brain goes up as we age, so it's arguably potentially part of programmed aging, but also strongly associated with disease or shrinkage of areas in the brain with Alzheimer's disease called the hippocampus. And in interventional models in animals, using a molecule like Xanamem to control the levels of cortisol in the brain is neuroprotective. In other words, it slows or stops that cognitive decline caused by the toxicity of cortisol. So what's unique about Xanamem is that it's the first molecule of its type targeting this enzyme that gets into the brain in adequate concentrations. And we've shown that with human scanning in the brain. So it's a really unique molecule. We've got good safety, and it has this ability to get to the brain where we need it to go.
Right. And so obviously, there's a big movement now towards anti-aging. I hear it talks about the 100-year-old Olympians that are going to be maybe our children or our grandchildren or something to that degree. And is that where Actinogen really comes into play, is to lengthen out not only our lives, but also obviously make us live a better, longer life?
Yeah, well, really, it's all about quality of life. So, a number of different companies around the world have been trying to explore ways to extend life, and that's a pretty big ask for a small to mid-sized company based here in Australia, albeit with global operations. But we're really focused on the science of cortisol. and the diseases where that has got the strongest linkages, because that will, of course, give us the highest chance of probability in our series of clinical trials and the highest chance of getting this drug to market in a reasonable period of time. And so Alzheimer's disease is absolutely a key disease for us. And really what we're trying to do with Alzheimer's is treat people in the early stages of sort of mild cognitive or mild difficulty thinking impairment, as it's called, and mild to moderate Alzheimer's disease, so that people with that disease can live an independent, healthy life for a few more years before they may need assisted care. So in other words, it's a quality of life thing, but very important because Alzheimer's is such a common disease. I think it's about 500,000 Australians have the disease, have dementia at any one time, and most of that is Alzheimer's disease. The second disease that we're really interested in is depression, because depression, particularly severe depression, is strongly associated with cortisol, and cognitive impairment, difficulty thinking, is almost universal in patients who are feeling depressed. And so there's a very strong lead from cortisol for depression. And then the third disease we're studying is Fragile X syndrome. We announced today that we're actually suspending the current global clinical trial because that trial was increasingly complex, and the cognitive benefits of manipulating cortisol in Fragile X syndrome are just one of a sort of a panoply of symptoms that such as anxiety, attention, and other things. And we're focusing the efforts of the company now on Alzheimer's and depression, where the cortisol hypothesis and cognition are essentially front and center.
Right. And I was just going to say, it also, does it from a corporate point of view, give you more of like a laser focus, so to speak? Because obviously, diminishing cortisol, there are probably so many applications for that, but at the end of the day, you have to choose, certain partners to dance with. So
yes, that's correct. So we've studied very carefully all of the science around cortisol and things that have been studied before and consulted broadly with our advisors. And Alzheimer's disease and depression are the two key diseases to study first, given that we've demonstrated cognitive enhancement in this series of 2 clinical trials to date, which is a really big deal in the world of cognition. So we would love to study Fragile X. If we can find appropriate industrial or academic partners, we may still study that, because there's people with Fragile X syndrome. There's a very strong scientific rationale for using this drug in that disease, but it is arguably considerably stronger for Alzheimer's disease and depression now that we have these new results.
Right. And speaking of them, you put out, I believe it was today or in the last few days, what I call the minimum effective dosage, or the dosage to, between 5 milligrams and 10 milligrams. Can you just explain it to, what is the importance of that, and what was the news, and for us non-scientists, please?
Sure. So originally the company went fairly quickly into what we call a phase 2 study. And so in other words, they did their healthy volunteer studies. It went up, you basically go up in levels of doses, showed that it was safe, and then did a relatively short 12-week study with a 10 milligram dose in patients with mild Alzheimer's disease. Most studies in Alzheimer's disease are at least 6 months long, and not surprisingly, the placebo group did not get worse during that trial, and the active treatment group did not get worse or better. And in other words, that trial was negative, but showed good safety. But the explanation at the time was that maybe the dose was too low. And so subsequently, the company did some brain scanning tests. We looked into the pharmacodynamics of the hormones related to cortisol called ACTH. And essentially all the data was saying, hey, and I think the dose was okay. It was probably the trial design that explained the negative result. We need to go back and look at this. At the same time, the company did a 20 milligram study showing improved working memory and attention. And this was really interesting. However, the brain scan data said, no, the minimally effective dose is going to be way less than 20. In order to develop a drug in a big market like depression or Alzheimer's disease, you have to go to the European and Australian and American authorities with convincing evidence of what we call dose ranging, or studying multiple different dose levels, so that you can take the minimally effective dose forward. It's really important because safety is such a big deal in marketed pharmaceuticals, of course, and we have excellent safety. So the new study of 5 milligrams and 10 milligrams versus placebo or a sugar pill showed that 5 and 10 had the same cognitive benefits as a 20 milligram dose. In other words, all of those other things that we know about the drug and the other clinical trials, it all points to this much lower dose range being fully effective. So we know now that the doses we should take forward are 10 milligrams or less, and we are moving quickly to design the next Alzheimer's disease patient study for the Alzheimer's program and a depression study for the depression program.
Okay, and speaking of those studies, can you just give us a timeline, like when would you expect them to take place?
Yeah, so we're planning to start both of those studies by the end of the year. And the company is increasingly focused on capital efficient Australian clinical trial operations, at least as the core for the majority of recruitment in those studies. And the reason to do this is several-fold. It's high quality clinical trial work that can be done here in Australia. We have excellent investigators. We have the R&D tax credit, of course, so that we get 43.5 cents back in our dollars for all of the Australian work that we do. And we just showed with this Xanamem Part A trial that we reported recently that we could enroll 107 people in under 5 months and do that trial in under a year. So in depression and in Alzheimer's disease patients, it's a bit tougher because those were healthy older volunteers. But nevertheless, we have the machinery and we have the skills and we have the team to really do efficient clinical trials based in Australia. So we're going to try and pursue that as much as possible.
Right, and because these are two such large target markets, is the one of the issues with recruitment obviously is always finding the patients. Is that easier just because so many people unfortunately do have Alzheimer's or depression?
Absolutely correct. So there are lots of people who are inadequately treated by their current antidepressants, and similarly, there are no really effective treatments for Alzheimer's disease. So unfortunately, there are lots of people who are accessible and willing to participate in clinical trials. So we think it's quite feasible to do the majority of the recruitment, if not all of it, here in Australia.
Right. So the trials, they'll start end of 2022, and
yep.
Would they run for, you said, 6 months?
So we haven't finalized the exact design of each of those trials. Depression trials are typically only 6 or 8 weeks long. They are pretty short treatment periods. Alzheimer's trials are typically 6 months long or greater. So that's a reasonable guidance, but we haven't finalized the design of those studies. In terms of how long the studies themselves will take, it will take between 12 to 18 months, more than likely, to do both of those studies. The depression study, if we're able to do that, recruit that as we expect, maybe a little bit faster than Alzheimer's disease, but it's too early to say.
Right. And is it too early to also say like what you would hope to see out of those trials?
Yeah, well, no, I can certainly paint a picture of that for you. So for Alzheimer's disease, what we're looking for is to repeat measurements of improved working memory and attention that we saw in healthy older volunteers, but also extend those findings, because in healthy volunteers, most of us have pretty good word recall and other executive function of capabilities, we call it. In patients with Alzheimer's disease, those are already impaired. So we hope to see that the drug has an effect on multiple domains of cognition, including things like executive function, which is the ability to solve problems, put a shopping list together or something like that. So those sort of things. So we basically are going to extend what we know about the drug's action in healthy volunteers to patients, extend hopefully the range of cognitive assessments that we show benefit on, and also hopefully see that after a 6-month or say trial treatment period versus placebo, that there's a really significant and big difference between the treated group and the placebo group, because there may be a possibility this drug slows the progression of the disease as well as giving you an immediate boost to your ability to think and remember things. For depression, we'll be measuring not just the effects on the ability to think, but also the effect on depression itself. Because there have been clinical trials of other drugs that with a different mechanism to manipulate the cortisol system. There's a drug called mifepristone, which in high doses blocks the glucocorticoid or cortisol receptor. And it did show some antidepressant effects. So we think Xanamem may well be both a cognitive improver and an antidepressant, and we'll be investigating both of those things.
Great. Stephen, turning towards more the world of biotech research, it's a global market because obviously whatever works here is going to work, conceivably all across the world.
Yep.
How do you manage understanding what else is taking place globally, as you said, to not replicate work that's already being done, and to also showcase to the world Actinogen, the company's progress so far?
Sure.
I need the drug.
Well, I get that a lot actually when I'm talking about Xanamem, because everybody can relate to not just a family member who has depression or Alzheimer's disease, but we all have moments where our memory or our problem-solving ability could use a boost, right? So anyway, but obviously to develop a drug that way would take a long, long time. And so we need to start with patients who have a high unmet medical need, like patients with early Alzheimer's or depression. But to answer your question quickly about how an Australian company like us operates in the world, we operate at a truly global level. So we are always in constant communication with a number of big and medium-sized pharma partners. It's just, you can imagine that the who's who of everybody in the world, right? They all have
Genentech, yes.
Yeah, they all have a big interest in this area. Some more than others, right? So not every company is interested in Alzheimer's, but some other ones are interested in depression. Some others are interested in Fragile X syndrome, and so a number of them I'll be speaking with in the coming weeks to give them the results. A lot of them have been eagerly awaiting the results of this trial. People in the world of cognition are quite fascinated by the fact that we have a pharmaceutical that can improve cognition in healthy older people. That is a very, very unique thing. And it is believed that will directly read over to being able to show similar things and better in patients once you start studying people who've got a deficit in cognition.
Right.
So we operate on a global scale, and then after the phase 2 program, the phase 3 studies will, by definition, need to expand globally, and the company would more than likely have clinical trial operations based in Europe and the US and Asia, as well as in Australia at that time.
Right. So suffice to say, if you're having breakthrough discoveries, you will get noticed.
Yes, indeed. And my job obviously is to talk about these results and put them into context and form the relationships with key people in the world of biotech, be that pharmaceutical partners, other key types of stakeholders, of course the academics involved, because a lot of academics these days are part industry, part academic, and so we have a big stakeholder universe. But the world is watching. If you talk to some of our key cognition advisors, a number of parties have been waiting with bated breath to see if our trial indeed read out positively, as it did.
Right. Fantastic. Fantastic. Hey, Steve, we try to keep it short because it is the middle of the day. Do you have any closing words before I open it up for questions and answers?
Oh, look, I mean, there's one other point I would make. We do have another set of data coming in the second half of 2022, which is our earliest data time point, which people might want to look out for. We're doing a reanalysis of some stored plasma samples from that phase 2 I mentioned with 10 milligrams over 12 weeks that didn't succeed in showing a clinical effect. But those data will show whether or not our drug is actually affecting the underlying biomarkers of amyloid, neuroinflammation. And we'll also reanalyze the study, understanding how the drug worked in patients with positive markers or biomarkers of amyloid. So that's a really interesting data point that will come later in the year, and that's a very inexpensive thing for us to do. So we're doing that Rather than run a whole new study, which would cost
Right.
millions of dollars, we can do a complete reanalysis with some of these new modern assays. So that's going to be a really interesting thing, potentially with the upside of showing in a very fast way that the drug is disease modifying and not just improving cognition.
Okay, what do you mean by disease modifying as opposed to just improving cognition?
So the hope is that a drug like Xanamem can actually slow down or stop the underlying cause of laying down amyloid and making the tangles happen in the brain that is the pathology of Alzheimer's disease.
Right.
And if cortisol is a significant player in that story, and we know cortisol is directly toxic if you just put it into a brain experimentally, you may be able to slow the deposition of amyloid. So companies like Biogen made this amyloid antibody. Lilly are doing the same thing to strip the amyloid out once it's already there. But maybe you can prevent it by using a drug like Xanamem to avoid laying it down or causing the damage to the brain in the first place. And measuring the change in biomarkers that you can measure these days in blood is a fast way of seeing whether that may be true or not. Now, it's not the same as actually doing a study of 18 months duration and proving it, but it's a really good surrogate for the potential of the drug.
Right. Got it. Okay, everybody, either feel free to ask a question or send me a WhatsApp. That's totally fine as well if you don't want to be on. Steve, I am getting somebody here just asking me the question.
Sure.
Does it matter with the patients what level of depression or Alzheimer's they already have before they go into the trial?
Yeah, it's a really good question that we think about carefully as we design each trial, because particularly for phase 2, you want a stable population that isn't too severe, that they've tried everything and essentially are untreatable, but you don't want people so mild that you can't measure a change. And so you sort of want patients who are stable, they've definitely got the disease, they're the type of patients that you want to treat in the future, but they're somewhere in the middle, would be my best answer to that question.
Okay. And then another question, and it's related to the balance sheet. They noticed that you have a lot of cash. Are you fully funded for this phase 2 trials?
Yes, so we have 19 million at the end of last quarter, and that gets supplemented by regular R&D tax credit rebates. We haven't finished the design of the phase 2 for either program, so we don't know exactly when that cash will run out, but it will last for quite a long time. So we're not making any definitive statements about everything being fully funded because we haven't got the final design. But suffice to say, we're in really good shape for the next 2 years.
Right, and I believe that the R&D credit in Australia is about 45%. Is that right?
Yes, 43.5%, I think.
Okay.
So it makes it's a bit like having an extra major investor around the table. It's a really good program. And has been without the dilution, and it has been a very successful program for Australia.
Yeah, and I guess that leads me to, you will for the trials, though, be trying to primarily recruit in Australia?
Yes.
And is it also just far easier to control everything because you are here?
Yeah, we're a Sydney-based company. We have important consultants in the UK and the US, but most of our operations and folks are on the east coast of Australia, but also we have people in West Australia too, and in Adelaide. So we actually are sort of a broad semi-virtual organisation. But as I mentioned before, we have this, with the last trial, a community model of recruitment that was highly efficient and successful. So rather than doing hospital clinics, which are expensive and slow, and they tend to have the sicker patients who have been treated by a million different things.
Right.
It's better, we find, to recruit in the community. And this is a movement in the global clinical trials world, is to actually have almost virtual clinical trials where you have recruitment centres that are based in the community, and you're actually better able to recruit patients in that middle sweet spot that I mentioned before, who are not too mild and not too severe.
Yeah, and I guess, is it also because, again, if you're targeting an extremely rare disease, is it that you just can't be as choosy because there are just fewer people?
Yes, so for Fragile X, part of the reason for us to look for another implementation and funding model for that study was that and we announced this a while back, we had to expand to the US to find enough sites and patients that would potentially come into that trial, even though it was a small trial of only 75 people. And to use a large number of international countries, you need to use a large contract research organization. There's a huge overhead, it's quite complex. And if you only do a couple of patients per site, there's a quality issue that you worry about, because the investigators and the coordinators doing the research, are they adequately remembering how to do it consistently and measure everything properly? So for that reason, you know, being able to do an Australian model, community recruitment, we've got local people who can be on site, checking quality, maintaining the progress of the trial. It makes a lot of sense. It's also capital efficient. So.
Right. I mean, I suppose that you even personally could go to some of these locations, and it just makes all the world of difference, I'm sure, to just be able to physically see people.
Indeed. Yep. With the last clinical trial, I went to several sites. That's right. And people really respond as well to the Australian story. So if we're recruiting Australian patients at Australian clinical sites, we're an Australian company, you know, having a new drug for Alzheimer's that has encouraging efficacy data already, it's quite a big story, and people feel good about it because of the Australian story for the beginning anyway. In the next phase after this, then we go global, and that's a whole different story.
Yes, well, we certainly meet here at the next CSL, so I hope that is Actinogen.
Thank you.
Stephen, thank you so much. Everybody, if you have any other questions afterwards, just send them to me or send them to Sean, and we'll make sure to talk to Stephen about it. Stephen, thank you very much for your time.
Thanks, Greg. Thanks for having me.
Thank you for watching another presentation by 180 Markets. Don't forget, if you want access to thousands of ASX capital raises, head on over to 180markets.com.au, sign up, and get on board for our very next capital raise. Thanks for watching.